Okay, next let's look at the downward rotators of the scapula or the shoulder girdle joint. And these are, the three are the levator scapula, the rhomboids, and the pec minor. And so once again, I'm just gonna kind of highlight some things from the textbook. I'm looking on page 15 at the levator scapula. It is named for its action, so it elevates the scapula, but it also is a downward rotator. And there's not a whole lot there, but you see in the little box, the levator is the elevator, and it works with upper trap. So if you've got, this is a common area of pain with patients. Maybe they're holding their phone this way or, doing some type of work where they've got that scapula elevated. That can really create a lot of pain and spasm through the upper trap and the levator area. I think you'll treat that, a lot in your career if you're in this for very long. On page 16 are the rhomboids. And again, I'm not going to read through all of the origin, insertion, action, innervation. I'm just giving you the highlights here. But rhomboids are another area. You see how they hook onto the vertebral border of the scapula, and those can have, a lot of trigger points. Patients complain of a lot of pain along that vertebral border. So we can use some of our manual techniques to help with those. This particular muscle is named for its shape. It's a rhomboid shape. So, and once again, it is a downward rotator. The last downward rotator is the pec minor. And there's nothing, too much else that I want to mention there. Again, make sure that you know the origin, insertion, action, and innervation. But so the three downward rotators that combine with shoulder extension, glenohumeral extension, are levator, scapula, rhomboids, and pec minor. Then I would, and again, I'm not, so if you look at your page where you marked all of the actions, what you're going to see is a complete balance. So 3 upward rotators are balanced by 3 downward rotators. The elevators are balanced by the depressors, and the protractors are balanced by the retractors. So it's really cool how that creates a balance. So the next muscle I want to talk about is the latissimus dorsi on page 20. And you see what a broad muscle it is. It actually starts up here on the thoracolumbar aponeurosis and the lower 6 spinous processes. But look how it has attachment to the pelvis. And so it's named, it says down in the little box again, latissimus means widest and dorsi means back. So it's the widest muscle of the back. It's a very important muscle for rehabilitation reasons. So you see how it attaches on the spine and the pelvis, and then it comes up and attaches on the shoulder. And so I want to just talk about, again, the box gives you the rest of the story. It's a powerful extensor of a flexed humerus and is active in such activities as swimming or chopping. So it is here. The arm is starting up at the top and it's coming down. So if you were chopping, that is the action of the latissimus. We did all kinds of strengthening of the latissimus in swimming, because as you bring your arm down and come here, that is its action. So the traditional actions of abduction, extension, medial rotation, and adduction really don't give you the full picture of the latissimus. And so if you would have just concentrated on those actions, you would have really missed the absolute beauty of the function of this muscle. Now, this is the open chain action. The closed chain action is kind of what I want to focus on. These are wheelchair push-ups or pushing down on a walker or crutches. It's a depressor of the scapula in the closed chain. It works in reverse action when the upper extremity is in weight bearing. And so this is very important, like I said, to push up for the patient to do their wheelchair pressure relief, to be able to push down on that assisted device, to take weight off of the lower extremity. That's the latissimus. And so you want to make sure that you're, looking at that in both the open chain and the closed chain and coming up with exercises. Even though it's a wide muscle, a big muscle, it does become atrophy, and a lot of our patients, particularly our elderly patients, may not have used their latissimus for a while. And so I think you can learn latissimus dorsi with teres major on page 25. I call the teres major the mini-me of the latissimus. If you look at it, this little slip of muscle has the exact same line of its fibers are oriented in the exact same way as latissimus. And so the actions are completely the same. The origin and insertion are the same. The innervation is different. So let's go back and pick up the sits muscles on page 21. We're starting with the supraspinatus. These are the rotator cuff, and you'll hear many patients call it rotary cup. And I always giggle when I hear that, but it's rotator cuff, and it's the sits muscles. So those four are the supraspinatus, the infraspinatus, the teres minor, and the subscapularis. Now, what I want to point out just a few things. The origin insertion, I think you'll get very easily. There are three that insert on the greater tubercle, and that's the supraspinatus, the infraspinatus, and the teres minor. The subscapularis inserts on the lesser tubercle, so its action is going to be different. But once again, if you just learn the traditional motions, you are really leaving out a huge part of what the rotator cuff does. And you could say this about any of the muscles and be right. On your quiz, if you write this in on your competency, you will not be wrong. They all stabilize the head of the humerus down and into the glenoid fossa. And so if they are not strong in keeping that head of the humerus down and into the glenoid fossa, the head of the humerus tends to ride upward superiorly. And there are lots of soft tissue structures, including the supraspinatus tendon that is running in between this illustration of my two hands. And so if that head of the humerus is bucking up against the acromion, that can create impingement. And so it's very important that we strengthen the rotator cuff. If you're thinking of the rotator cuff as doing this motion, that is correct. The three do external rotation, subscap does internal rotation. If you're looking at the way a baseball player moves their arm, and lots of tennis players and people with overhead activities, they are at risk for rotator cuff injury because of that action, that repetitive action. But the other part of it is that it's helping control the rotation down and into the glenoid fossa this way. And so stabilizing the head of the humerus down and into the socket, that's a big functional piece of the rotator cuff. And so that's one reason that initially when we start on shoulder rehab, we're going to try to strengthen the rotator cuff with the arm to the side, positioned down to the side, not so much up here. When the arm elevates, that's when we can get into that impingement, which is not what we want. And so, the box down here tells the rest of the story. Now, supraspinatus, its fibers tend to run a little bit more horizontally, so it will actually initiate glenohumeral abduction. The mid-delts, the middle deltoid, is is the strongest shoulder abductor. But since its fibers are situated so vertically, it cannot initiate abduction. Supraspinatus must initiate it, and then middle deltoids can take it over. And so, supraspinatus, infraspinatus, teres minor are all there. They've got those traditional actions. That's fine. We want you to learn those. But again, the rest of the story is the fact that it reinforces the capsule and keeps the head of the humerus down and into the fossa. So I think that's a good discussion on those. The other thing I want to talk about, I want to point your attention to, let's look at the biceps. And again, I'm not going through every single muscle, but the ones on the list are the ones that you'll be tested on. I'm just highlighting what I think are the most important parts of the muscles as a combination. But say for biceps, you'll notice that the action, please do not just write flexion. That will be counted wrong on your quiz. The biceps crosses two joints, and so does the triceps. So anytime a muscle crosses two joints, you need to list out both of those joints. Shoulder flexion and elbow flexion, and in this case, the biceps also supinates. So make sure that you're hitting all of those. You will see, again, the musculocutaneous nerve that we looked at. So generally speaking, the elbow flexors are innervated by musculocutaneous. Brachioradialis is the exception. It's innervated by the radial nerve. So you can kind of remember that because it's got the radial part. So biceps, brachialis, and coracobrachialis are all innervated by the musculocutaneous nerve. You will see that their spinal nerve root level is C5, C6. So that's why on the upper quarter screening, we used elbow flexion to assess the myotome of C6 because of those elbow flexors. Brachialis, it does mention as the strongest elbow flexor, which is kind of interesting. I would normally think that maybe the biceps would be. But on triceps, again, don't just tell me that it extends. I want to hear you, you'll need to write down it's an extensor of the glenohumeral joint or the humerus, and it's also an extensor of the elbow. And not a whole lot there, except I would say this is a good place to start understanding that the radial nerve innervates the posteriorly situated muscles, including the triceps. So the radial nerve in general will produce extension of the elbow and the wrist and hand. And so if someone has a radial nerve injury, what they end up with is a wrist drop. This is not a very functional hand, is it? So that's why you'll see, splints. We want to put them in a cock-up wrist splint so that wrist is held in a nice neutral, if not a little bit of extended position until hopefully the nerve heals. So just make sure, again, you're learning origin, insertion, action, and innervation. And then we get into the wrist, the long wrist muscles, either the flexors or the extensors. And so on page 31, generally speaking, the wrist, you can get the actions based off of the name. Flexor, so it flexes. Carpi means wrist, and then radialis. So it's also going to pick up radial deviation. It's situated on the radial side of the forearm, so it will radially deviate. So you can get a lot of the wrist actions just by knowing the name. Now, the other part of this discussion is remembering that, and this is information that you need to carry forth, but the origin of the flexors of the wrist are the medial epicondyle of the humerus, and you see the common flexor tendon. And so if I'm palpating that, I've got to come above the elbow, and I'm going to be out here. I'm not down here. This is where the tendon is coming from. but it's gonna originate up high. So the flexors will originate off of the medial epicondyle of the humerus. The extensors, the wrist extensors, will originate off of the lateral epicondyle of the humerus. And one way that I remember that is I take my wrist, I cock it up into extension, I give myself an isometric break, and I can kind of see, you know, where that muscle bulk is and that it's coming up laterally. That's one way that you can remember the difference between the wrist extensor origin being the lateral humeral epicondyle and the flexor tendons originating off of the medial epicondyle. So a lot of the humerus, so make sure that you're identifying humerus. You know, when we get into the lower extremity, there's epicondyles for femur and tibia. So you've got to know the difference. So you might as well just start now with medial epicondyle of the humerus. And then you'll begin to notice the ulnar, anything with an ulnaris. In this case, flexor carpi ulnaris is innervated by the ulnar nerve, C8 or C7-C8. So again, that's why we use the muscles that we used for upper quarter screening, because those were the muscles that were innervated by that particular nerve root. So we go through here. Pollicis means thumb. So, you know, if you see that word, that's going to be action at the thumb. The brachioradialis is the only elbow flexor that is innervated by the radial nerve, not the musculocutaneous nerve. So there's some differences. And then I just wanted to mention the small intrinsic muscles of the hand. And we have not included all of these, but if their origin insertion is distal to the wrist, it's going to be called an intrinsic muscle. So the fine motor types of movements of your hand, including the thumb for opposition. And so anything that attaches above the wrist is called an extrinsic hand muscle. And so we have not included all of these little intrinsics, and I just always put this out there. If you see more muscles on your state board than what we included in our study, please get in touch with me, let me know, and we'll make it more difficult for the next group. You don't necessarily want your life to be harder at this point, but we will. I always say that, and very rarely do I have people come back and say, you didn't cover enough on muscles. But again, these are mostly I think you could at least get the action, flexor pollicis brevis, so it's going to flex the thumb, extensor pollicis longus, it's going to extend the thumb. So I think just knowing the names of the muscles, you could probably at least guess the action of them. So we have been a little bit nice and not included everything on the wrist and hand. And then you finally do get back to the lumbricals and the palmar and dorsal interossei. The lumbricals do this. They flex the MP and joints and they extend the PIP and the DIP. So I always remember when I was little, we'd turn off the lights and just have a flashlight, and we would make different motions with our hand with the shadow. And that's the lumbricals. You'll see the lumbrical grip, which is this, which you could be serving a plate that way by gripping a plate and serving it. Or in the old days when we used to read newspapers, we would grip the sides of the newspaper this way. That's the lumbricals. The interossei, the palmar and the dorsal interossei, you have all of the origin, insertion, and actions there. But the palmar, you can remember, are the adductors, pad, and the dorsal are the abductors, dab. And you will notice that by the time we get down to the intrinsics, hand muscles, all of those have, now we have full upper extremity function with innervation from C8 to T1. So that means our spinal cord injury patients who are even at a T1 level, which remember here is C7, so the next one down would be T1. That's pretty high up on the spinal cord. So even that high up on the spinal cord, if the patient would have a spinal cord injury, they would still have complete and full use of their upper extremities. And that is a big deal, to be able to have your entire, your shoulder girdles, all of your deltoids, your sits, your elbow flexors, your triceps, your biceps, your wrist movement, and your hand movement. That's a big deal when we talk about rehabilitation with our spinal cord injury patients. And so that is in a nutshell what I wanted to cover with what I think are the more important points, other than just the traditional origin, insertion, action, and innervation for the muscle. Please make sure that you do go through all of the muscles that are on the list that way with your note cards. And if you haven't ventured to the back of the book, like starting on page 61, it will separate out like by the action, like in this case, elevators of the scapula, and it gives the upper trap and lower trap, or I'm sorry, upper trap and levator. So, I think there is a lot of really good information in the back part of the text for the upper extremity muscles, all the way through the distribution of the various nerves, and it'll list out the muscle that's innervated by that particular peripheral nerve. So I hope that helps you study. Again, please make sure that you're looking at those little boxes down in the corner, because they really do give you the rest of the story, and sometimes the more important parts of the story to the muscles.